Before I deal with pancreatitis, I would like to introduce the pancreas. And the pancreas is a fleshy organ situated in the upper abdomen. And its primary function is to secrete enzyme to digest food. And this is its exocrine function. Additionally, and simplistically put, its endocrine function is to help regulate glucose metabolism, and it secretes insulin to ensure that the blood glucose levels in the body are maintained. Now, pancreatitis, and for the purpose of this interview, acute pancreatitis is what I'm going to be talking about, is inflammation of the pancreas that occurs suddenly. And why this occurs is as a result of insult to the exocrine cell, which is called the acinar cell. Now, the acinar cell gets injured and it initiates a cascade within the cell, outside the cell, in the neural and vascular pathways to try and trigger a local and systemic inflammatory response. Now, this response could be mild, which is most often the result of severity in patients, and that occurs in about 80% of the cases. But the worry is that it can cause severe inflammation and it can affect organs in about 20%, leading to necrosis, organ failure, and death. That is why this is a major concern. Patients, when they present to hospital, most often to the emergency department, present with very severe and sudden onset of pain, mostly in the upper abdomen. They have associated nausea and vomiting several times, and they may be dehydrated as well. So this is a real concern for patients, and they need emergency medical help, and that's how they present. The recommendation is that you should seek medical help almost immediately or as soon as possible, because you need to first recognize the problem and diagnose it. Once you've done that, then you would need stabilization following resuscitation that occurs most often in a hospital or a medical environment, followed by the assessment of the severity of the attack. What happens is that we will have to rule out other causes that mimic pancreatitis. So that is, in the initial period, the assessment as such. Once we've determined that this is pancreatitis and assessed and stabilized the patient, so then we have got to find the ultimate cause of why it occurred, to then embark on definitively treating it. Because we know in about 80% of cases, the cause is often, in 40% of cases, gallstones, or in 40% of people, excess alcohol. Now, there are other obscure causes that shouldn't be ignored, but what we have to focus is these are the main causes of pancreatitis. The treatment of pancreatitis in the initial period is often in a hospital environment where the treatment administered is conservative and supportive. As we know, in 80% of cases, the attack is expected to be self-limiting and mild, but often the treatment involves diagnosis and recognition, and that is often based on how the patient presents. If the patient has severe pain, mostly in the epigastrium or the upper abdomen, associated with vomiting and nausea, and then we often do blood tests, and the specific test that we run is a serum amylase level in the blood or the serum lipase. If that is 3 times the upper limit of normal, that is highly indicative of pancreatitis. If there is a diagnostic uncertainty, we often resort to doing a CT scan. So if 2 out of the 3, which is the presentation, the blood test, and the scan suggests pancreatitis, then we confirm the diagnosis. Now, once the diagnosis is confirmed, then we embark on the stabilization and resuscitation of patients with fluid therapy, anti-sickness medications as they're violently sick, and analgesic therapy, which to try and reduce their pain. Simultaneously, we would be assessing the severity of the attack by watching out for any organ dysfunction, namely the kidneys, the lungs, the heart, and the gut. So what we have to try and do is try and maintain function of these vital organs to ensure that they're working well. If there is concern that these organs are malfunctioning, then the patients would need to be moved to a higher level of care, which would involve intensive care therapy to try and support these organs, because we do not want these organs to go into failure. Because in about 20% of cases, this can occur, and then these organs are vitally supported in the intensive care unit. Now, having stabilized and resuscitated, and if the patients respond and if the attack is mild, then we would then go on to try and ascertain the cause. And if the cause is often stone disease detected on an ultrasound scan where there is gallstones in the gallbladder, then the patient, after stabilization, and if the patient recovers, then we would then recommend an operation to deal with the gallstones in the gallbladder by removing the gallbladder within 2 weeks of the attack. So that is the recommended treatment. In the event the patient has got alcohol-related issues and the attack is as a result of excess alcohol, then he would be directed to a alcohol liaison team to try and help with the addiction, reduce it, and ideally stop it. And in the further 20% of cases where there is a very severe attack, some of these patients end up staying in hospital for several weeks or months because the affected organs fail and then they will need to recover. What we clearly worry about in this group of patients is the extent of the death of the pancreas gland itself, its liquefaction, and the need for drainage of the sepsis, and then achieving control and thereby finally getting the patient out of hospital to then assess, as we say, what the remnant damage would be, because the gland often heals by scarring. And once it scars, that means function cannot be restored, and there is a higher risk that the patients become diabetic or would need enzyme therapy to help digest food additionally. This is often a chronic state that may develop as a result of a very bad previous attack or recurrent smaller attacks. So this is often dealt with a group of professionals who are actually proficient physicians or surgeons who have got knowledge and are tuned and trained to deal with pancreatitis. So it is a multidisciplinary team approach where the patients are attended to, and often in a hospital environment. In the rare event this is left untreated, we would have to look at two scenarios where it is a very mild, self-remitting attack where the pain occurs for a short period and resolves, and the patient kind of thinks that it is just heartburn or something that is not important and lives through it. But if this was to be borne in mind that if this was to recur, it may well recur in a severe manner, and there is a 20% risk that could happen year on year. And that attack would be highly severe, which could then lead up to you having organ dysfunction or organ failure and landing up in an intensive care unit. So the recommendation is to not sit on it at home, but seek medical help. And even if it is for reassurance, that is reasonable, because you do not want to be put in a situation where you are extremely ill, requiring hospitalization, and then ending up in hospital. Now, the other scenario is that you've had an attack of pancreatitis, you've recovered, but then there is a risk that if the definitive treatment is not offered, i.e., if you have had gallstones, if the gallstones are not removed, or if you're still drinking, this is about in 80% of cases the cause, then the risk remains that you may put yourself at greater risk that they would have another attack which would be severe. So it is important that you seek help, and from a group of highly trained physicians who are or surgeons who deal with the pancreas, who could then help you. Because untreated, you could put yourself at risk of developing organ dysfunction, organ failure, and exposing yourself to a scenario where you're potentially facing death, which could be entirely preventable. As human beings, we need to acknowledge that we have certain non-modifiable risks, which are genetic, and modifiable risks that we indulge in as a result of our behaviors and our interactions with the environment. Now, prevention is a vital component of treatment, often neglected. And my advice and my take on treatment preventions in pancreatitis is to follow the middle path or moderation. We can't do much about our genetic risks, but at least we can be familiar with them. We can, inquire from our parents, grandparents, if there has been a history of pancreatitis, and then get screened, because the history of pancreatitis runs in families, and there are certain genetic abnormalities that predispose you to develop the condition of acute pancreatitis. And this is a hereditary syndrome in a small minority of cases. So if you have a family history, please do go get tested, because then you put yourself at least reduce the risk, and you seek help. Additionally, the recurrent attacks of pancreatitis put you at risk, at least in the familial context, a higher risk of developing a cancer, you see. So thereby, it becomes incumbent on you to seek help. In the other group of patients where there is a modifiable risk, i.e., you enjoy life, or you are drinking excessively, you're living the life, but what happens is it catches up. And what you have to think about is how it affects you and your organs. And the pancreas is greatly affected by excess alcohol drinking, binge drinking, and one should curtail and stick to the prescribed units of alcohol a week, and try and avoid excessive alcohol consumption. And if you've had pancreatitis, think about giving it up altogether, because it's not worth it. The other risks associated with developing pancreatitis is, of course, fatty food, rich food, and one should try and curtail the amount of fat one ingests or intakes in one's diet. And then, of course, try and give up smoking if you do, and then exercise at least 1 hour a week. Or not a week, I would say 1 hour a day. That's very important. If you exercise and do all these things, I'm sure the pancreas would stay healthy.